Good morning, Peter Goertz. I'm a psychiatrist. If you feel secure as a doctor, like you can handle any situation, in my opinion, think again. You can always get blindsided. I recently gave another talk, and I'm going to mention some of the things that came up during that talk. One thing is, a lot of psychiatrists seem concerned about patients seeing notes that they wrote. And I understand that if you write something about a patient feeling very depressed, being suicidal, those are really personal things. And in my opinion, though, I've actually, as far as I recall, I've never tried to prevent a patient from reading the notes that I wrote about them. So different psychiatrists have different views, but I think one thing that is worth doing, and that's what I do, basically, whenever you write a note about a patient, try and imagine that the patient is sitting right next to you or looking over your shoulder and reading the note. So I think you can pretty much write about anything as long as you write about it in a way that is respectful. So even if someone comes in saying, "Doc, I need you to prescribe me 6 milligrams of Xanax a day and 60 milligrams of Adderall, and I'm also on opioid medication, which another doctor is prescribing," you can describe that scenario without saying something like patient is drug seeking. So anything that could be seen as derogatory by the patient you want to leave out. So you could just be descriptive. Patient comes in requesting that I prescribe 6 milligrams of Xanax a day, etc. And that's a neutral way of stating that. And different institutions may be different. In our institution at this point, my understanding is that patients cannot read the notes by their psychiatrists unless the psychiatrist gives them permission. I had actually been under the understanding until recently that they could read their notes, and either way though, I'm writing them so that they can read them. So I don't think I've ever denied a patient permission to read their notes that I wrote. Another aspect is pretty obvious aspect. If we're trying to be respectful toward patients, our actions need to show that. So if you walk into an office of a psychiatrist and the psychiatrist has a big armchair and the patient has a little stool, no matter how much the psychiatrist says, "I respect you, you're worthy, you're deserving of being treated like any other human being," the actions of the psychiatrist are not congruent with that. So the chair of the psychiatrist is much more comfortable than the chair of the patient, and that right away tells the patient something, tells anyone something when they walk into that office. Another thing that can blindside you is, and it's not funny, you can really miss information, but it can be pretty striking and potentially comical. So even if a patient has dementia, is delirious, is a child, in my opinion, at least what I want to do is talk with the patient alone first before letting the family come into the visit, let's say a parent, a child. Because even again, if someone's a child, even if they're delirious, demented, they may want to tell you something first alone before a family member is in the room. For example, if you want to get basic history also, some things may not be things that the patient has ever shared with their family. For instance, like sexual abuse in childhood, the patient may have cheated on his wife, or vice versa, the wife may have cheated on the husband and never told the husband. Criminal history, they may not have divulged. Substance use, gambling, all those things, personal things, they may not have divulged. So that's my practice, and the family member may get a little annoyed if they come in with a patient and want to talk with you and you say right away, I'm sorry, I'm going to talk with the patient first. But that's what I do. And then I let the family member join, which probably also is not optimal. Ideally, you want to speak with the family members separately also. So actually, it's probably wiser than having the family. You can have the family member come in, but additionally, you probably actually want to talk with the family member on the phone separately from the patient, because the family member may also not feel comfortable divulging certain things while the patient is in the room. The scenarios we see can be quite confusing, can blindside you also. I remember about 10 years ago, I had 2 new patients, new evaluation patients scheduled back to back. And I see the gentleman, and he was the one that was scheduled first. One was a male, the next one was a female. And then I start seeing the wife, and I think, well, maybe the gentleman already told me, my wife is scheduled to see you right after me, or the wife told me when I started seeing her. But the first patient was the husband, the second patient was the husband's wife. And I hadn't known that when they were scheduled. I think they may have had different last names even. So that was confusing. And in my opinion, that's not a great idea to, on an ongoing basis, see a husband for individual psychiatric treatment or for psychotherapy for that matter, and also see the wife for psychiatric treatment or psychotherapy for the same reasons. You know, let's say the wife or the husband says, I'm cheating on my spouse, and they don't know it. And then by mistake, that you may blurt that out, you know, just because you're not thinking of it in the visit with the other person, with the other member, with the other spouse. So it's wise, in my opinion, to not see spouses or even friends, people who know each other well on an ongoing basis, because again, things can slip out and there can be boundary issues. How do you deal with verbally abusive patients? Do you like to be verbally abused? I'm sure you don't. I don't think anyone does. And that can happen. So not infrequently, especially on inpatient wards, but I'm talking more about the clinic now. Even in a clinic, it can happen. You don't know anything. You don't know what you're doing. They can talk about your looks, whatever. People can pick up on things, and especially manic patients, borderline personality disorder patients, they can be quite astute in pushing your buttons, or potentially pushing your buttons if you let them. And that can be a tricky situation. So how do you deal with someone who's outright verbally abusive, cursing at you during a visit? On the one hand, in my opinion, you want to provide an environment where patients can basically let loose, tell you about things that are personal, cry, get angry. But it has to, in my opinion, be within a certain framework, certain boundaries that feel more or less comfortable, or comfortable to you. They have to feel comfortable to you. So if it goes beyond a certain level of abuse or duration of abuse, my sense would be, for me, I would then say, you need to be courteous. We're going to have to end the visit if you're not courteous. And if that continues, we're going to have to end the treatment if you're not courteous. So just like I respect you, you have to act in a way that's respectful to me. Another aspect is patients may ask quite personal questions just out of the blue. You know, you're talking about medicine and the patient may say, are you married? Are you homosexual? Are you heterosexual? What is your political orientation? What is your salary? What is your religious belief, if you have religious beliefs? What is your ethnic background? And often I do answer those questions. I don't necessarily feel uncomfortable answering them. They're no one's business really, but if I feel comfortable, I answer them, and often I do. But if it feels intrusive, if it feels like the patient is spending a lot of time on that, often I do set boundaries and say, it's your visit, let's talk about you, because that really is actually the purpose of the visit. What about potentially assaultive patients? That can be a very difficult situation. And one basic thing you want to look at is, what is the seating like in your office? Who is closer to the door? So if you're working with psychiatric patients, I think it's wise to have your seat closer to the door than the patient's seat, and maybe if possible, even a desk between the patient and the door, so that the patient cannot block you from exiting the office if the patient gets agitated. So that's one basic thing to think of. If you walk into an office that you're supposed to use and the patient's seat is closer to the door, probably not a wise thing. How do you deal with patients being late? What I do is I do my very best to be punctual, start the visits on time, end the visits on time so I can see the next patient on time. And generally I do that, and the patients know that. So that gives you some leverage. Let's say if the patient is late, then you have the leverage because you start on time and the patient knows that's your process of starting on time. So what you can do, let's say a patient comes in 25 minutes late, there are only 5 minutes left in the visit and they want to be seen, then I tell the patient, we can sit down for 5 minutes, but that's it. And that may just be, are you suicidal, homicidal? If the patient wants to talk about adjusting their medicine, I can tell them then, I'm sorry, we don't have the time to do that. We can do that at the next visit. And if the patient cancels at short notice, it's another issue. Or if the patient doesn't show up for visits, that's a problem. If you're in private practice, you can tell the patient about your practice. Let's say you may let the patient know that if the patient cancels within less than 24 hours, they're gonna have to pay out of pocket, or I don't know if their insurance would cover, probably not. So they may have to pay out of pocket for their visit if they cancel with less than 24 hours notice, or if they don't show up. So if you're in private practice, you can set your own guidelines and make your own policy and let the patient know about it. If you're working in an institution, you do have to abide by the policy of the institution regarding late cancellations, so within less than 24 hours, or no-shows. And that can be tricky because then you may have to continue seeing patients who have no-showed. So in our institution, there is a policy, if there are repeated no-shows, then ultimately we can let the patient know that they need to seek care elsewhere in another institution because they're not engaged in treatment to the point where they're not showing up for more than one visit, and that makes it really difficult and potentially impossible for us to treat the patient adequately. How do you deal with it if a patient comes into your visit and just opens up an illegal, pulls an illegal drug out of their pocket right in your office? We're not police, but probably not a good idea for patients to bring drugs into a clinic, and you want to let them know that. That's just not something that's acceptable in our clinic if that's an issue for the patient. Can we treat alcohol withdrawal as an outpatient? I've done it. Probably not a great idea. It's better for the patient to be in a detox facility, but if they refuse that, I've done it. It is possible, let's say with Valium, to detox a patient at home, but you have to feel comfortable doing that it has to be a patient whom you trust, and it's not necessarily a great idea in general to do, but again, if you trust the patient, it seems like something that is a possibility. And for that patient, actually, that worked out well. That patient, she was able to get off alcohol with the help of a Valium taper. Thank you.